Next slide. So we're hosting this session on the unceded and ancestral territory of the Coast Salish peoples. That includes the territories of the Musqueam, the Squamish, and Tsleil-Waututh nations, and the Métis Charter community of the Lower Mainland region. And all of you around this province and Turtle Island are coming from territories that have been cared for and nurtured since time immemorial by the peoples on it. And we've all committed, I believe, to learn much more about the people, their ways, and how we can help to maintain all of those. Next slide. So province-wide rounds, as you know, is a collaboration between the University of British Columbia Division of Nephrology and BC Renal. We're very grateful to all of the health authorities as well as our industry partners for enabling us to have a very full agenda with broad representation from all of our partners so that we can live and learn together, but importantly, do all of this in the best interest of taking the best care of our patients in the current moment. So thank you all for that participation. Next slide. So these are these Health Authority Renal Program presentations. That's what HARP stands for. And we have a couple of presentations, one from PHC and one from Interior Health. And these are intended to showcase the various activities that are going on within the health authorities by groups of interdisciplinary groups of individuals. So I'll introduce very briefly our presenters. Dr. Bev Jung is a clinical associate professor with the Division of Nephrology, UBC Department of Medicine based at St. Paul's, and is the medical co-director for the Vancouver Coastal Community Dialysis Units since 2008 with a major interest in hemodialysis. Jessica Pan is the Indigenous Engagement Specialist with the Indigenous Wellness and Reconciliation Team at Providence Health Care. As a settler and uninvited guest, she's been honored to be invited to do work to service both urban and on-reserve Indigenous communities in the past 8 years. And we look forward to her presentation. And Amy Hamil holds a BSN, a master's and a graduate certificate in emergency nursing, as well as an international clinical fellowship program completion. She has 21 years of global experience and is a results-oriented registered nurse with a strong background in operations, quality improvement, and advanced scope of practice. And she's currently our lead in the renal program at Providence Health Care. And Rebecca Parton from Interior Health is the clinical operations manager for renal services across the Thompson, Caribou, and Shuswap region. And she leads the strategic delivery of kidney care across the diverse sites, the 3 diverse sites within the Interior Health Authority as an educator in nephrology and peritoneal dialysis. At BCIT, she's contributed to really substantially to the next generation of nephrology nurses. So without taking any more of the time away from you, I'd like to hand it over to our presenters and thank you for the work you do and the presentations we're about to hear. Over to you guys.
Thank you so much, Dr. Levin. Before I start off, I want to acknowledge that I'm also calling in from the unceded territories of the Coast Salish people, particularly the Musqueam, the Squamish, and the Tsleil-Waututh, where I'm privileged to live, work, and play. Today I'll be co-presenting with Jessica Pan and Dr. Young, and we'll be focusing on the community dialysis centres in Metro Vancouver. And without further ado, I will hand over to Dr. Young.
Yes, as a matter of fact, this project started in 2023 when the Providence Health Care Renal leadership wished to honor and acknowledge the lands that our community dialysis units are situated as part of the reconciliation process. So the PHC Indigenous Engagement Team was consulted to discuss with the knowledge keepers about how they would like to showcase their knowledge of kidney health. The chosen concept of bringing nature to the indoors, I believe, will contribute to holistic and spiritual healing of our patients. And once the installations are completed, we hope the Indigenous elders would participate in a ceremony so that we can show our appreciation. I will now pass on the rest of the presentation to Jessica, who will show you more details and show you how it will look.
Awesome. So thank you for everyone's time today. I don't usually get to do presentations, so I'm really grateful to get to speak on this exciting project with the team. My role is I have to acknowledge that I'm a settler myself. I'm an uninvited guest from Hong Kong and have been really lucky to get to steward this work. Um, for those that do or do not know, um, at Providence, we have a mandate and a commitment to embed reconciliation in everything we do. And when I joined PHC, I was really in awe of that commitment because that means that there is, of course, the cultural safety education, and there is also then the commitment to decolonize in other aspects, including physical spaces, which are the projects that I get to do with and across all our facilities. So built environment is for those that do or do not know the concept, it's essentially the physical elements you see in a space, how our space is designed. And we see that as being a really important facet for Indigenous patients to also see themselves and their identity positively affirmed in a space. And when we know of Indigenous patient experience in healthcare, a lot of times even subtle things in the spaces could be a trigger or could be a negative factor to preventing them from seeking care. So across all our sites and across, of course, this is a rendering of New St. Paul's Hospital, and which I could talk to folks later if they're interested. But across all our facilities, as we are slowly working on renovating or doing any retrofitting of spaces, we are mindful of how are we ensuring that there is a cultural safety element in spaces so that Indigenous patients particularly feel safe accessing our care. So at Providence, and this was before my time, an anchor to the New St. Paul's Hospital experience in trying to build this big infrastructure, there was an extensive engagement completed with host nations representatives, with the Indigenous organizations that support the patient population in community and other Indigenous groups around what does culturally safe care look like. So I like to talk of myself as the walking, talking Indigenous design guidelines, as the guidelines was meant to be very kind of recognizing that there's other factors to how we design spaces, like infection control, but ensuring that this is an element and we are flexible to ensuring that Indigenous voices are represented. So this is a tool, and we've been iterating and learning from how we can make this tool better to help with how we design spaces across all our healthcare facilities. So for this particular project, and for a lot of others, we've been using this tool called wall wraps or environmental wall graphics. It's been a really interesting tool for us as it offers us an opportunity to have a big impact to bring in Indigenous worldview, to daylight Indigenous land history, and to really showcase what are the cultures of the nations that we are on their unceded territories for. And for those that do not know, wall graphics are essentially giant wall stickers. They're relatively low cost. It is kind of a laminated wall covering, so infection control really appreciates that. And it is scalable, which you'll see as we're able to use the same imagery across multiple sites and beyond as we need to. So in terms of process, the team had come to our Indigenous Wellness and Reconciliation team. And what I do is I then reach out to the knowledge keepers. And in this case, there is an ethnobotanist we get to work with from Squamish Nation, who is really gifted around what are the traditional medicines of the land and what are the traditional medicines that would have been used and is still used for certain clinical areas, and in this case, for kidney health. And our intention with these kind of big wall wraps, and in certain spaces you'll see as you come to St. Paul sites and as we bring more projects online, is that sometimes they are talking about that worldview of how have Indigenous people of this land taken care of their kidney health. And in other spaces, we've been able to convey this was what the land used to be pre-contact at St. Paul's Hospital, where we now colonially know it as downtown Vancouver. So it really helps convey that welcoming, that and what we also do is there's an educational plaque that accompanies that really describe what was the cultural significance of what we're trying to display. And what we're now kind of in the Western world coming alongside is knowing that Indigenous worldview has always known that nature is healing and nature has a way of supporting holistic wellness. But in the Western context, we call it biophilic design, which is a way of bringing in nature into built environments, into indoor spaces, because as humans, we've now moved indoors with the advent of electricity and lights, but really we are ultimately creatures who need to attach to other life forms, other nature. And we know, and research does show, how nature and natural materials and views of nature help support patient recovery, help staff satisfaction in a workplace, help reduce the use of pain medication, and in a healthcare context with infection control considerations, imagery of nature is kind of the closest way we can get to that. So for the community dialysis unit sites, and those that are particular to Metro Vancouver sites, because we do have locations that are outside of Musqueam, Squamish, and Tsleil-Waututh territories. For our Metro Vancouver sites, the plant medicine that's been chosen by the ethnobotanist and knowledge keeper is the Canada Goldenrod, which you'll see a picture here. And I have to say, as someone who didn't know as much about plants as I do now, it's been a real gift to learn from what are Indigenous species, what are nature's pharmacy that is right outside our front doors. And now that you see it, you can't unsee the influences in the plant life that you see out there in the wild. And yellow goldenrod now in this season would not be in this thriving yellow as you see here, but you still see there's remnants of them and little fluffs of as they kind of dry into seed and propagate more of the plants. And shown below in this bottom right is the plaque that we have accompanying all our visual imagery and wall wraps. And sorry, I'm going to move all the people so I can see it myself. So here is a draft. We are still, in working with the knowledge keepers, we ensure that we provide a bit of context of what is this plant. And here you'll see there's a bit of a description of how the Musqueam, Squamish, and Tsleil-Waututh peoples have harnessed the power of plant medicines to support healing and wellness. And then we describe what this plant is used for in a very high level way, respecting that we wouldn't want to kind of give people a recipe of what to do with this particular plant, as that wouldn't be appropriate. But what's really interesting about plant medicines, and here you'll also see we are trying to represent the two languages that the three host nations share here. But the challenge with language is a lot of language has been lost over time due to what's been done to Indigenous peoples, and we get to work with the knowledge keepers around revitalizing language, and sometimes that can be challenging with the few knowledge keepers around language that still hold on to the bits of language. So that is the piece that we're working through before we can proceed with completing this project. So now is, I think, the exciting part where the visualization from the renderings from the graphic designer we've been working with. And here I'm going to kind of go through some slides of the renderings that we expect to see for the Metro Vancouver sites. So here you'll see in kind of central Vancouver, in East Vancouver, and essentially you see that this is where this project really speaks to that scalability. We are repurposing the same graphic, of course, adapted to each of the sites, and are able to display this way of Indigenous ways of knowing into these clinical spaces, which will be really lovely. And next steps. So the wall wraps, those are renderings. They're very good renderings because when I show people those images, they're like, is it done? No, they're not quite done yet, but we expect to install in the coming weeks, pending that work with the language keeper to finalize the content and make sure it is proper and appropriate. So that is our kind of next big step. Cultural safety education. We never want to put up something and expect that people will know what it means and what is the significance of what we're doing. So cultural safety education for staff, and recognizing that will be an ongoing journey for how we embed culturally safe learnings and teachings and ways of being with Indigenous patients and infuse that way of being amongst the staff team. And here is just just a visual, not very exciting, but we did create a frequently asked questions that really gives like a quick speaking points to staff who might need to respond to patient questions around why did you do this? What is this about? And then as kind of the next steps with anything we do, patient feedback, ongoing engagement, evaluation, I will say I've been with Providence for almost 2 years now, and with my role was bringing online these wall wraps, and we hope, but we want to see that in the form of evaluation, whether it is making the feedback or making the impact we're intending for patient welcoming and that sense of safety when they enter our spaces. And we hope this spreads. We hope this approach and this way of decolonizing spaces is inspiring for other sites, and we can keep moving forward with this way of working. At Providence, I will say we have projects in almost every site, so we are slowly making our way to ensuring that spaces feel culturally safe. And this is only one of the tools we're using amongst others to ensure cultural safety at our facilities. Any more to add, Amy or Dr. Young?
I was just going to say, Jessica, that was brilliant. Thank you so much. So in terms of education, so education will be ongoing. It's will be part of our orientation and multidisciplinary. And I also want to just give a shout out to Gillian Piper, our patient care manager, who's been instrumental to this work over the last 12 months.
Great. Thank you so much. Does anybody on the call have any questions or comments? I think it's a phenomenal model going forward. Really, congratulations in embedding all of this work in planning of the spaces. Just looking to see who else is on the call to see if I can single anyone out, but I don't think I can. So we'll do think of some questions, and perhaps we'll move on to our next presentation. Would that be okay, Rebecca? Terrific.
Absolutely.
Yeah, thank you, team. That was really great. Really inspiring.
All right, good morning, everyone. I'd like to take a moment to start this presentation in a good way by providing a land acknowledgement. I would like to recognize and acknowledge the traditional, ancestral, and unceded territories of the Decolonizing, Tuna'a, Ingla Ketma, Shwepmium, Statlium, Salix, and Chakotay nations where I live, learn, and share this environment together, as well as I'd also like to recognize the important contributions of our Inuit and Métis partners today. So my name is Rebecca Kovich, previously Parton, and I'm currently the co-chair of the Home Therapies Committee. I would like to highlight the work today that our Home Therapies team has accomplished over the last year, and that was led by our previous co-chair, Jessie Colbeck. I have the privilege of taking this work on and putting it into action, and so I'd like to share that work with you today. So today, we are going to meet Alice. Alice is a fictional representative of a peritoneal dialysis population, and for the purposes of this presentation, she's a lovely 79-year-old lady who lives with her husband, Edward. Their children live on the coast and they visit for special events. Edward is quite elderly himself and he needs help in his day-to-day. Alice has had a few health complications in the past few years, and she has chosen PD so she can stay at home and help with her husband. Like Alice, many of us have different fears in our life. I have highlighted some common ones here. So feel free to post in the chat or take yourself off mute and share your feel. Feel free to share fears that I have not included on the slide listed as well. Perfect. So for Alice, her biggest fear is changes in her health. These changes in her health. Any change to her health would not only impact her, but also her husband, Edward. Unfortunately, Alice's worst fear came true, and she suffered a stroke, which also led to a fall, causing a hip fracture. Her ability to perform her own care is now gone. She is staying in hospital and unable to return home. Her days look like this. That's generally a day in the hospital that she has to face every single day. She needs to make a decision to get out of this hospital, and she's starting to weigh her options. She can either go palliative or lose her therapy of choice and start hemodialysis treatment in center. She does not want in-center treatment and finds the idea of traveling every other day too exhausting and cannot see any quality of life with this option. Luckily for Alice and others like her, the home therapies team has created a solution for her. Our program is peritoneal dialysis in long-term care settings. The home therapies team worked to integrate home health, long-term care, and PD services. Together, strategic goals were aligned, which allowed prioritized work and partnerships to ensure that care transition from their home to home and community service needs and long-term care home service was seamless. The home therapies team worked to integrate these services and provide the skill set needed to support PD population transitioning into long-term care. Without the associated additional education and competency validation, many of these services have been unavailable to our patients, like Alice, who may want to choose to continue their PD in addition to 24/7 professional nursing care. This program ensures a seamless, person-centered, and collaborative care approach as they transition between independent living, home health, and long-term care services. The standardization process aims to enhance continuity, improve access to care, and optimize quality of life by ensuring active patient involvement in all aspects of care planning, implementing standardized additional education training, and identifying roles and responsibilities of our clinical teams. A few important documents were created to ensure that everyone's roles and responsibilities were clearly defined. We created the Access to Long-Term Care for PD Patients, which sets the standards for care delivery and identifies the care pathway and monitoring of our patients. We also created the PD Implementation Model, which outlines the specific roles and responsibilities and communication framework, the PD Admission Checklist, and we also created a PD to long-term care shared email inbox, which allows a centralized communication for the long-term care home to not only request initial, but also ongoing education in the program. The basis of this program is to accurately identify a PD patient in an upstream fashion. So factors that the PD clinicians would consider are those at a high risk for LTC placement, over 80, caregiver dependent, they're having respite requests. The second piece is then to take those identified patients, and the PD nurse will alert home health, the nephrologist, and the social worker. This multidisciplinary team will then explore if long-term care is desirable and if they are aware of the option to have their services in long-term care should they need that. Once the family consents to the idea of long-term care placement, the renal team with the home health care will collaborate with a potential long-term care site. The final piece is that home therapy's regional educator will meet with the LTC site to determine education needs and provide the education, set up supplies for the home. The patient can then be transitioned to care, and ongoing long-term care site and refreshers will be provided. For the patient journey, there's each step in a little bit more detail. So ideally, the PD team would identify the PD patient that can no longer self-manage and implement the PD Assist program if appropriate. They would receive consent from PD to initiate home health referral, which is submitted electronically through our Meditech or electronic health records program. We are monitoring regularly each PD patient so we can identify readily for additional supports. Home health, upon the receipt of the referral, will complete the required assessments. They will also begin the bed matching process as appropriate based on assessments and supports that are needed. The bed matching system now incorporates the need for peritoneal dialysis in long-term care. This step allows for patients, like Alice, that are in hospital to begin their journey here when they can be matched with a home that can provide their care and get them discharged from the hospital sooner. The long-term care home will then match with the patient. They will designate space for the PD supplies and create a temporary care plan. They will also book their staff in for the PD training. The PD care team at this point will work the long-term care home to develop a care plan and work with PD order sets and orders appropriate supplies. Once sufficient amount of staff are trained and the supplies have been delivered, we ensure that patient readiness is addressed so that they meet the LTC eligibility criteria and can be safely discharged from hospital if they are in hospital. The patient is then transferred to their new long-term care home. The long-term care home will support care planning between the geographical PD clinic and the long-term care home. They will obtain the renal blood work along with theirs and are able to troubleshoot equipment and complications. Long-term care homes will also update the PD clinic of any medication changes and ensures that the resident can attend those PD clinics as needed. The long-term care home will continue to monitor the need for education and refreshers and reach out as appropriate. Over time, the long-term care home may use PD education as a part of their orientation process. But for next steps, we have one home currently being trained to perform PD, and we have a second home on the wait list for training for PD. We will continue to grow additional sites to ensure that PD care is spread throughout the interior region, creating equitable PD access for patients at any stage in their life and any time of their care. Opportunity for questions.
Thank you so much for that. And I think it's a challenge that everyone's been trying to manage. So I'd be interested if other people had questions, but I think every time we've tried to do this, the issue is with the fact that there's not enough people at any one time going to any one long-term care facility to maintain the interest and the skill set. So I'm curious how you've managed to do that. It's fantastic that you can get different long-term care facilities to agree to this. And so I think many on the call know that we've tried this a number of different times in different locations. And because not enough people are there at one time, it sort of falls off. So what do you think is different about your approach?
We're very fortunate in that we have a regional PD lead, and so she's the one who is solely in charge of educating the long-term care home. So she will travel to that specific home that requires it, which is handy that it's not reliant on the geographical PD clinic to supply that care and education, because when it comes down to the PD clinic in the geographical region, there can be challenges with staffing and competency and maintaining the ability to support two homes plus their own program. So she is dedicated to that service, and so that she can also offer refreshers to the long-term care home. So maybe initially they have a long-term care home, they take a PD patient, they have their training, and that patient passes away in maybe 6 months to a year, and then they can just get a refresher for it. They've already done it once. So we have refresher programs that are annual. We also have we built specialized education for PD and long-term care that the long-term care homes can keep as well. So they can also use their educator at site to do refreshers. We can also do little mini education sessions to support in between. There's a lot of written information they can review. And if it's quite some time, we just come back in and redo the whole staff again as needed for it. So we try and designate a couple homes in each area that would be PD and long-term care focused. But again, if the family chooses one that's not one of those and the long-term care home is willing to participate, we're happy to do the education and supply that support for them too. And I think just having that centralized email communication piece is also really important. It allows the long-term care home to continually interact with us and provides that centralized communication piece so that they're just directly interacting with our regional clinical educator. So she can just take care of those emails and just directly liaise with the long-term care home and connect other long-term care homes that already have PD and long-term care so they can see supports and we can learn from each other.
Yeah, there's a couple of questions in the chat. So one is how many staff are trained and is there a process for long-term care staff getting recertified? I think you've sort of answered that. And are you training APD or CAPD?
We'll train both or either or depending what the patient needs are. So twin bags are obviously easier, but cycler is nicer if they're on the cycler because it's that longer therapy and they can generally do that overnight. So we'll train whichever therapy the patient is engaging in. for that. And so it's usually a couple day sessions that we'll do there, and we'll do the targeted staff that are generally full-time. So it takes a lot of coordination with the long-term care home manager to arrange the staff that need to be appropriate. And we'll spend usually a week or two at the site to make sure that we cycle through enough staff. So we'll have a lot of pre-reading education. There'll be some online support and the actual hands-on done by a regional educator at site. And then if they're not feeling comfortable, we would of course extend that or come back and do a check-in too, depending how it's going. But we'd offer both options. The cycler is nice for the overnight care, and a lot of our patients prefer that. So that way during the daytime recreation therapy can still see them, they can still go out, participate in activities in the long-term care home. So the cycler they still have their 1-800 number to call. It's not owner-sum for everybody to troubleshoot. And then we also help with supply ordering too if there's issues with that. So the clinical educator navigates that piece as well for the staff.
Great. And I guess what's the total number of patients that you have at the moment in interior? Because I think that's the other thing. I look at my Vancouver Coastal Providence Health Care colleagues and around like there's always been the problem with not enough people to create the what's the word I want, the momentum and maintain it. So I'm just wondering what the total number in interior health that are potential or in long-term care.
So right now we have one long-term care home training, and we'll have a second one set up. It's again, it's a very challenging population to set up for. So we've targeted people that have been in hospital that are trying to transition to long-term care and using those two as our kind of pilot people with that. And then as we grow, whereas at the very infant stages of this too. So we'll have to see what the maintenance piece looks like for it. But we have those two homes that are generally the mainstays of where they would transition from in hospital to go to long-term care. We focused on those homes in particular for that to get patients out of hospital.
Well, yeah, what I was saying is how many patients? Like, are there like 5 people waiting or 2 people or?
We have 2 people that
Okay.
that would be part of our program right now. And there's additional other ones potentially on the wait list. We're continually monitoring them on a monthly basis. And we have a tracker to kind of see if they're needing that PD assist care, if they're needing a home health referral, and to kind of start that process. So within that group, we have about 8 patients that are between the PD assist needing the home health referral stage. So they're all kind of within different stages of the program. But the actual training, implementation, ordering supplies, the end stage of that program, we have 2 patients there.
Terrific. Thank you. Any other questions or comments? Daniel, you have your hand up.
Thanks for your presentation. I know in Fraser, we've really struggled with long-term care. We've had some great successes, but also a lot of setbacks. One of the things that's really striking to me is that both in the publicly administered and the privately owned facilities, we've really had a lot of objection to our patients. And at the end of the day, to me at least, it seems that we just lack a unified sense of why this is important. So I'm really just curious, like, how did you get the folks who are decision makers around to a yes? Because that's the hardest thing. The logistics, I think, are actually very manageable, but getting people to agree is very hard.
Absolutely. It was a lot of developing those coalitions for sure, because we needed to have home health. We needed to change our strata pathways, the program placement for long-term care criteria as well, so that homes couldn't just see that and then automatically deny as well, because it's the same barrier that we also face as well, that people don't want the additional training or the additional skill sets too. So it did take upper level advocacy as well. So our directors and our executive directors also had to be on board. They were strategically aligning with them, improving equity of care along PD. So I think just having the same strategic direction and prioritizing that as increased hospital stays is kind of why those 2 patients are the beginning pilot ones, is because of the number of days they're staying in hospital, because there's an adequate placement for them, and having to choose either palliation or hemodialysis for the patient too. So having that advocacy absolutely at the executive director level and director level was monumental to get everyone on the same page.
Great. And Donna, you have your hand up too.
Yeah, can you hear me okay?
Yep.
Okay, good. So I'm Donna. I work with Rebecca, the director of the program, and just a couple of pieces to add, and great presentation, Rebecca. This has been a years-long journey, and the real tipping point for us is about a year ago, we had a new to Interior Health executive director join our program from another province that does this and has done this service for years in that province. So he brought his experience and his energy and we will get this done to our program, to be quite frank. He said, I know of no reason why we cannot and should not be doing this in our health authority. He brought his knowledge and his we will get this done to our program. And that really was the tipping point for us. So he's an executive director that has the responsibility for the senior services in our health authority. He made this happen, to be really blunt. We had been facing barrier after barrier after barrier, and could not get this through. So it was a real collaboration with our senior services, our professional practice office, our renal program. It seemed like we would make a couple steps forward and then we would hit a barrier in another program. It wasn't within our control. It wasn't the renal program or practice that could get this through on our own. So earlier on, we had trained the staff in a long-term care home in the South Okanagan, and unfortunately, that patient passed away before we could actually have her benefit from the service and move into that site. She'd been in the hospital, I can't remember now, but I think almost a year. Then we move forward to what Rebecca was sharing. We have a site being trained right now and another one waiting. We have had, I think, 9 or 10 patients that had been identified as possibly being suitable for this care. We have faced and still face a lot of resistance from our long-term care programs, much what was just shared, not understanding the benefit to the people that would receive the service, excuse me, reluctance in paying for staff to be trained. We have some sites that are relying on agency staff and reluctance in paying for agency staff to be trained. It just goes on and on. So when a new person is identified as being possibly a benefit for this type of care, we almost go through several steps again with the support of this executive director responsible for seniors care. So it's still, although we have the ability to bring the service in for people, we still have to go through a lot of advocacy and say, yes, we do this, we provide this in our health authority, and we need to move forward with it for training within your site. The site has to have a leader with, I will do this, I believe in this, I'm the champion for it. Otherwise, we continue to face a lot of adversity, really.
I think that's what everyone was alluding to, and kudos for the persistence. And I think it does describe, it highlights the need for integration across a number of portfolios, because acute care and chronic care and dialysis care, they're all kind of not in the right space sometimes to put this together. Suni, you have another comment or question?
Yeah, I mean, I think what was just discussed is one of the issues, is that often these programs become dependent on 1 or 2 people who are able to sustain and maintain it. And then if that person is gone, you have to end up restarting the whole thing over again for a very small population. So I think that, there are places in the world where this is just done everywhere and it isn't dependent on one person. It's just established like for the whole province that it will be done. But that's hard to do when you have so few people. Like in places like France, where it's everybody who's on dialysis in a long-term care facility is defaulted to PD rather than having to create it for 1 or 2 people coming in. So eventually, if we can get it into the grassroots, that will be the best. But I think right now it's just like amazing amount of work and effort. And luckily you have someone who can go to each individual place and do education that isn't, that doesn't have a huge other role. So, I know how much work it is in Vancouver Coastal. We had it, then we just weren't able to sustain it. And the work of having to do it all over again can just be exhausting. So congratulations to you for doing that.
Yeah. No, and I mean, it's interesting, right? I want to bring it back to our earlier presentation in terms of acknowledging Indigenous ways of knowing and doing. And I think that, our perhaps disrespect for elders in our colonial world should be contrasted to the respect that Indigenous peoples have for the elders. And perhaps we could learn from each other a little bit how to Sunit's point, embed this. This is the way we take care of old people in our society, right? It's not okay to do the wrong thing by them. And so to your point, but that requires ongoing advocacy. And perhaps, if IH can do it with this kind of centralized, decentralized model, then maybe that's something that the other large health authorities, obviously working with a champion, because I think there's clearly that need, could propagate this a little bit. So yeah, I think it's wonderful, that you've done this, and to Sunit and everyone else's point, it's hard to sustain it. It's hard to sustain it when it's not embedded in the system and the systems don't talk to each other. But perhaps this gives impetus from a provincial perspective, to sort of create this hub and spoke model in each of the health authorities, and then use each other to bounce it off and sustain it. But any other questions or thoughts from the audience? So I want to thank all of our presenters, both for innovation in creating safe spaces, visually and surrounding, and a safe space for old people to maintain their quality of life and not be brought back and forth. So I really appreciate the innovation and dedication of all of the teams. And I think we all do. And again, as an attempt to learn with and from each other, I think this has been an excellent session. So thank you so much for the preparation, but more importantly, the work that you've done. So happy Friday, everybody.